Great. Thank you so much. Yeah. Good evening to everybody who is present here. Thank you so much for being present and sparing your precious time to us all. And we hope to bring practical topics which are going to be helpful and easy for you to follow and understand and help you in your renal nutrition practice. Thanks to True Healthy for providing us with the technical support here. So we begin with our first webinar of the year 2024. And as we all know, technology is changing with a lot of dynamics in the technology happening now, and with the AI also coming into picture. The use of technology in aiding or in helping and supporting the renal patients is something which we have been thinking and discussing about. So, throwing an insight into these would be Dr. Dhananjay Kalkar, our prestigious speaker, and Dr. Manju George. I'll quickly introduce our first speaker for the evening. So Dr. Dhananjay Kalkar, he is a nephrologist practicing at Ashwini Kidney and Dialysis Center in Nagpur. Sir has an experience of more than 3 decades, and Sir comes with immense knowledge. And it's always a pleasure to listen to him and talk to him and discuss with him. Sir has various achievements and awards backing him. He has contributed majorly towards the guidelines for hemodialysis developed by the Indian Society of Nephrology. He also has been a part of many courses which have been started for dialysis technicians. He also has received a Lifetime Achievement Award by Nephrology Society in Nagpur. I also have been involved with certain lot of paper publications and a lot of activities. Thank you so much for sparing your time and coming here today, sir. Thank you so much. I'll hand over the screen to you now, and you can start with your presentation, sir.
Thank you, Himani. Thanks for the kind words. This is a unique topic, and I'm really thankful to the organizers because they have thought about this topic. Chronic kidney disease is a major problem, and let me begin by highlighting the global scope of the problem caused by chronic kidney disease. Chronic kidney disease is a progressive decline in renal function, as all of you know, which lasts for more than 3 months. This problem affects approximately 10 to 15% of the world's population, amounting to 8,436 million people as of in 2017. It affects mainly the diabetics and the hypertensive, women, the racial minorities, and the elderly. And what is striking is the rapidity at which this is becoming a leading cause of death. From the 19th leading cause of death in somewhere in 2013, it is projected to be fifth leading cause of death by 2040. It has already reached this position in Singapore, in Israel, and one more place. So it's a very important problem for all of us to tackle, more so because we happen to be in the low and medium economies of the world where this problem is growing at a phenomenal rate. India and China will see the most growth in chronic kidney disease patients, and it is very expensive treatment. Treatment is very expensive. Some of the major challenges that we have in controlling the chronic kidney disease epidemic is that the diagnosis is usually made late because as as of now all over the world we depend on the patient to come to us with a symptom for his evaluation to begin. Now symptoms come up in stage 4 and stage 5 of the chronic kidney disease. Stage 1, 2, and 3 are often asymptomatic, and that is the point at which we could make a difference. Second challenge as far as chronic kidney disease is that 60% of CKD is caused by diseases like diabetes and hypertension, which are lifestyle diseases. And these lifestyle diseases do not go with a pill. They require a consistent modification of human behavior over a prolonged period. Advanced disease, like I said just now, is very expensive. The US economy is burdened by a very small fraction of patients who continue to remain on dialysis or transplant. So much so now that the US spends about 20% of its GDP on treatment of chronic kidney disease, which is a very expensive way of dealing with this problem. And there is no way that economies like Indian economy would be able to give dialysis to all of its patients. And it disproportionately affects the poor individuals and the poor countries. So we need to find out, since our current technology is not enough to handle this problem, some new technologies need to be explored. But first, let us understand what is a technology. Because if you go and open any business newspaper, you will find it to be used synonymously with information technology. That's wrong. That's only one type of technology. Actually, the word technology means the use of scientific knowledge for practical purposes or applications, whether it be in industry or in everyday life. It is not necessarily information technology. So, technology has evolved. Newer technologies are being introduced, from food production to food processing, building roads to energy. And each of these domains, technology has evolved. We now have better roads because of advanced technology, but also we have more vehicles on these roads, leading to carbon emission and global warming. Our communication has changed from the books to the mobile, and our attention span has come down to few seconds. Last score was 8 seconds. Technology has made food processing move from the gas to the microwave. So each of these technology advances has changed our lifestyle. Chronic kidney disease is largely caused by lifestyle diseases, which like diabetes, which is linked to a sedentary lifestyle, hypertension, which is linked to high salt content of our food, and the rapid deterioration of our environment and deforestation has contributed to global warming. So we need to look at technology from two angles. Technology as a solution for chronic kidney disease. If you see this symbol, this is a Chinese symbol. This is a symbol used to express threat, but it is also the symbol in Chinese for opportunity. So technology will cause problems, and technology also will become a solution if we use it rightly. The problem of chronic kidney disease starts from the beginning. Beginning of any renal evaluation is a urine examination. Chronic kidney disease affects the woman more than the men after a certain age group, and in women it progresses quite rapidly. But urine routine examination in a female is problematic from the point of method of collecting urine, because the method of collecting urine is unhygienic, awkward, and messy. So this is, I hope you can see this visual. This is a small innovation, technological, where urine is collected in a paper receptacle like a funnel, and this makes it cleaner and less messier. The error rate in interpretation is also goes down with the use of this technology. So the point I want to make is technology is not always expensive. It can be very simple with a paper apparatus. As I said, early detection of chronic kidney disease is difficult because symptoms come very late. In majority of the patients, one of the earliest indicators of CKD is appearance of proteinuria, and therefore an annual urine examination in the high risk population will pick up this proteinuria. But for that, the patient will have to travel to the laboratory, give his urine sample, collect the reports, and then communicate with his doctor. Each of these tasks will involve commitment and time. No wonder less than 20% of the target population complies with this requirement in the developed world. This is a new technology which uses the smartphone technology to test the urine at home. A kit is shipped to the patient, and in that kit there is a paper strip which can test for albumin creatinine. After dipping that paper strip in this urine, it is inserted here in this receptacle, and then a photograph is taken with a mobile camera, and that photograph is analyzed by by an app, and urine albumin creatinine ratio is displayed on the monitor, and it can also be sent to the treating doctor. So this was used in a community in the United States, and they found that earlier, where there was 20% of urine albumin creatinine ratio screening, it jumped to 70% of the target population. So we need to look again at each step in the process of CKD diagnosis and come up and identify the pain points, and then come up with some technological innovation which will reduce the pain point and increase the yield. For example, blood pressure monitoring. Everybody knows that we need to keep the blood pressure less than 130 by 85 to retard the rate of progress of chronic kidney disease. But measuring blood pressure has come a long way. Stephen Hales was the first person, English clergyman, who inserted a rod into the artery of a mare and then measured the pressure of the column of blood, and then measured the blood pressure. Later, we had better technique. The mercury BP apparatus came up, then the digital BP apparatus, which we are using nowadays. But the digital BP apparatus requires a regular change of batteries, and it has a lot of tubes. It is not easy to travel to take in a travel, and blood pressure cannot be shared easily with the treating doctor. This leads to a delay in the transfer of this vital information to the doctor. Consequently, there is a delay in the modification of treatment. So these are the new innovations and technological advances that has occurred. We have this Apple wristwatch, which is a wearable which can monitor the pulse, the blood pressure, and few other parameters also. But this is expensive, the Apple wristwatch. This is another innovation. This is from Withings company, and this blood pressure apparatus. Look at the blood pressure apparatus; it is so sleek, without any wires, without any tubings, and a very tight fitting cuff, uh, which is there. And the second good thing is this battery lasts for more than 6 months after one recharge, after one charging. So it is very easy to take in the travel. And another advantage is this can be synchronized via Wi-Fi or Bluetooth with a free app, uh, and therefore the doctor can also have that app, and he can monitor the blood pressure of the patient. It's very easy to carry in the travel, but it costs about 12,000 rupees per piece in India. There are many apps which are developed for management of chronic kidney disease. The question is, which app should I use? There is a instrument known as Mars. Mars is mobile app rating scale, and this rating scale uses four broad categories of criteria. One is how engaging is the app. Second, what is its functionality? Thirdly, what are its aesthetics, and how reliable is the information? And along with that, one subjective quality scale. So there are a number of apps available on the Google Play Store or as well as on the Apple Store. But there are some apps which have no relevance to CKD. If you just write down chronic kidney disease app, you might even find an app which has Dr. Santa Claus, so which has no relevance with CKD. So, and therefore, this paper, which looked at the reliability of the apps, which are the best apps, they found out that 11 out of the 12 apps met the minimum acceptable score of 3 in the Mars rating. And if you want, you can write it down. There are three apps with the highest combined score were My Kidneys, My Health Handbook with a score of 4.68. The second app was My Food Coach with a score of 4.48. And the National Kidney Foundation Malaysia's app 4 point, with a score of 4.20. These were the considered to be the best apps. Some other apps which are also acceptable with a score of more than 3 uh, are the CKD Go, which I'm going to mention in a few minutes' time. So CKD Go is an app which helps us in improving the compliance of the treating doctor with the guidelines. Because it's very difficult to remember all the long list of interventions which have to be done. And hence, there is a poor compliance with the guidelines. And often, important interventions are missed in the patient care. So, let me show you this app. This app will have this opening interface where you have a CKD calculator and a CKD handbook. Now, the CKD calculator will ask whether the patient is a female or a male, and what is the individual's EGFR. If the at the same level of EGFR, if proteinuria is less, then you have a green signal. That is, the rate of progress of CKD is not likely to be very high. As the EGFR rises, it will go into yellow, and then lastly, it will go into red. So there are three broad categories: yellow, green, and red. You see, the EGFR is stable at 60, but the proteinuria is rising, and as it crosses about 40 milligram per millimole, the red zone starts. That is, this individual is likely to have the most rapid progress of renal function. And therefore, you will get two main uh, inputs: what should be the management goals in this individual, and what are the management strategies. For an individual with a red zone, there are many management goals. Sorry, there are many management goals, but for an individual with a green or a yellow, the management goals are reduced, as well as the actions and strategies are also reduced. The CKD Go app also has other information about in the handbook, and for want of time, I will not go into the details, but you can explore that app. It's a very good app and very useful app available on the Play Store. Blood sugar monitoring is often essential because the better the blood sugar is controlled in a diabetic, HbA1c is maintained around 7, the less is the rate of decline of glomerular filtration rate. Unfortunately, the current technology necessitates frequent pricking to collect blood for blood sugar testing. And early morning hypoglycemias or hyperglycemias are often missed because they start coming more frequently as renal function deteriorates in a diabetic. But who would get up at 3 o'clock in the morning, prick his finger, and get his blood sugar? Very few. So this app, this new technology, sensor technology, helps us in picking up the blood sugars without any prick. This is an Abbott device, and you can take about 1,440 readings without a prick and get multiple graphs and trends. You can know when the sugars are going up, when they're going down, what is the average blood sugar. The cost of this device is around 4,000 rupees, and it offers real-time glucose data, trends, and customizable alarms, which are fed directly to your smartphone or the reader. So smartphone is good, and smartphone is very useful. It can be used for self-monitoring. It can be used for medication monitoring. It can be used as health education monitoring and lifestyle education. So the Nephrology Society, Malaysian Nephrology Society, has come up with this a very useful app, which is useful for this. Now, let me put up a case for changing from paper based records to an electronic medical record, a technology which has already come in the West but should be there in India, widely accepted. Because, for example, if you want to have about 30 kg paper, you would have to cut a 3 to 4 years old tree to get that 30 kg paper. Secondly, paper based medical records are notorious for getting mutilated, for information to be lost, for difficulty in analyzing that information. So I think we should go beyond this paper based records and adapt this technology of electronic medical records universally. Secondly, paper based medical records choke the information flow. And what is information is heavily centered with the doctor or with the hospital. And chronic kidney disease management requires a partnership between patients and his healthcare teams. So, patient portals would be a very important technology to adopt early, because the patient can then fix up his appointment, cancel his appointment, send messages to his healthcare workers, look up his own lab reports and his medication. So, in a large study, they found that all this improves the patient centered outcomes. What are patient centered outcomes? The patient centered outcomes are chronic kidney disease knowledge, CKD induced stress, perceived health status. And once these patient can centered outcomes are improved, clinical outcomes of retarding the rate of progress of renal failure will follow. Another new technology, which to my mind is very useful and has already proved itself during the corona pandemic, is telemedicine. It can it can run a telenephrology clinic where the patient can avoid traveling and yet consult the doctor. You could have a e-consult between the primary care physician, the general practitioner, and the nephrologist who are situated in distant geography via video conferencing. You can create a virtual support group for patients. They need not come to the hospital to meet to have a group support activity. Can be at their own homes. They can use social media platforms like WhatsApp and Facebook Messenger. You can disseminate information to create awareness. And awareness creation is very crucial. Education is very important, like what Dr. Sanjay Pandya does with his Suraksha Kidney Key. These kinds of websites will uh, will facilitate transfer of information and correct treatment. But management of chronic kidney disease is not only giving information. Changing behavior requires positive reinforcement. So, for example, brushing the teeth. Now, all of us brush our teeth, but we do not know which side of the teeth are properly brushed or not brushed. This Colgate electric toothbrush synchronizes with the mobile, and at the end of the brushing session, you will know how long have you brushed, which are the edges and sides of the teeth that has been left out, and as you improve that, you get a positive reinforcement the next day of where you were lacking last yesterday and where are you now today. So we need positive reinforcement to change behavior, and we need to use these technologies. And Himani referred to artificial intelligence, and these are the promising technologies which are coming up. Let's look at them. So, artificial intelligence is a program that enables the computer to mimic human behavior. Part of the artificial intelligence domain is machine learning, in which the a statistical method is used to build on the program and make inferences or projections. And deep learning is how multi-layered neural networks learn from the vast amount of data. Now, to put it in perspective, question is, when the patient of chronic kidney disease comes to your OPD for the first time, can you predict whether he is going to have a rapid decline in renal function or whether his decline in renal function will be slow? Somebody who has a more rapid decline in renal function, you would want him to come to the OPD more frequently. You would want to monitor his blood pressure and blood sugars more aggressively and his dietary management more aggressively, give him more time for counseling and health education. But how do you know that when he comes for the first time? So, this machine learning model helps you in predicting the rate of decline of renal function to a fairly accurate level. Another new technology which is coming up, which is going to revolutionize the way we treat chronic kidney disease, is the stem cell therapy. So, kidneys, once they are damaged and creatinine goes above 2, it will be a progressive disease. There are, if it has stuck for more than 3 months, EGFR is stuck below 60 ml for more than 3 months, then chances are bleak that they would be completely reversed. But one therapy which promises to do that is the stem cell therapy. The mesenchymal stem cells are introduced into the blood, and they can reduce inflammation, they can reduce apoptosis or cell death, they can differentiate into multiple renal tissues, and they can self replicate. This is still work in action, and uh, we will have to wait for some time before we actually start practicing it. But another important issue which I want to discuss now with you is how nephrology itself is becoming a cause for worsening of chronic kidney disease, the practice of nephrology. Look at this very busy chart, and this is the contribution of healthcare to national carbon footprints. In the United States, because of healthcare, the because of 7.6% of the national carbon footprint is because of healthcare. In India, our contribution is only 1.5%. That does not necessarily mean that we are better than the United States healthcare, but it could also mean the relative lack of healthcare in our country. But if we follow the US model of more roads, more cars on the roads, more deforestation, more use once and throw away consumables, we will see that we would be very soon catching up with the United States. So we need to consider whether we can copy the United States model blindly, or we need to find a new model by using technologies to reduce carbon footprints and thereby reducing the incidence of chronic kidney disease. One such, like I already alluded to, is to reduce the need for people to travel for something which can be done in their home. The more the travel, the more is the carbon emission. In a landmark study from the United States, they found out air pollution to be very closely linked with chronic kidney disease incidence across the United States. Those cities which had more air pollution had more CKD incidence. The rural areas were relatively spared. So, to sum up, I would like to say that we should use technological innovation in all aspects of life, and information technology is just one type of technology, but technological innovations in all aspects will really help in reducing the scope as well as the impact of chronic kidney disease. And we need to be on the cutting edge of technology to reduce the impact of CKD. Thank you.
Thank you so much, sir. Thank you for such a wonderful and lucid presentation and in very simple words. We'll now head over to our second speaker for the evening, and then we can take the questions collectively for both of you. So if you could stop sharing your screen.
Yeah.
So if anybody has any questions, please feel free to put them in the question answer section here, and we'll be answering them collectively. So our second speaker now is Dr. Manju George. So a lot of dietitians here already know Dr. Manju George. I don't need to introduce her much, but still, she's a chief dietitian working at VPS Lakeshore Hospital. She comes with an experience of 18 years and certified diabetes educator. She has received a lot of rewards and titles to her credit. She has also received the International Inspire Award 2022 as the most inspiring clinical nutritionist dietitian. She has received citation from Srimati Anandiben Patel, the Honorable Governor of UP, as a part of winning the IIPA National Award in February 2021. She has been also awarded as the Best Organizer and Best Employee at the British Biologicals. She's an academic counselor for IGNOU and lecturer at the nurse education courses and various certified CDE courses. She's a member of various prestigious institutes and organizations and has a lot of publications to her credit. So with this, we begin with Dr. Manju George. And Manju, I'll be sharing your screen. So sharing your slides. So just let me know if you need any help from me
Sure.
here. Yeah.
Sure. Thank you, Ms. Himani. Thank you for the invite. And I'll be very happy to deliver a few thoughts on the use of technology in managing CKD patients in a dietitian's perspective. And to much appreciation. Doctor, session 2 was very good, and it will be in continuation with the session. And I was very happy to listen to this topic, because this was my PhD research topic. AI integrated cloud-based digital diet consultation tool development was my topic, and it was much closer to this thing, so that I could present my research data also. So with this introduction, let me start. I'll be touching on the few medical nutrition therapy aspects initially, and then followed by how apps can be useful in the consultation for the CKD patients. Next slide. We know that the renal patients are associated with malnutrition in different ways because of multiple reasons, like metabolic acidosis, decreased food intake, absorption, and recurrent infection. So this all together put them at risk. And we know the stages of, next slide, stages of chronic kidney disease. And the 5 stages are marked with parameters as listed here. And we know that each stage requires specialized nutrition approach in terms of micronutrients, especially with the role of electrolytes. So what do we need to look at? Next slide. We have to look at energy, protein, like all the macro and micro, along with this electrolyte balance, fluid balance, all these needs to be there. Next slide. And the aims of the renal diet will be to replace nutrients, maintain optimal nutritional status, and decrease the waste buildup. So that should be the ultimate approach, and how effectively we can see to support patients based on this. Next slide. In conservative CKD management, the nutrition goal varies. Same wise, next slide. In the hemodialysis and peritoneal dialysis also, all the nutrient goals are changing. But even though the goal is so high, the patient may not be able to take up so much what we prescribe or try to provide to them. So each on a daily basis, we need a personalized approach and a follow-up in this regard. Next slide. In spite of us knowing that the junk food intake and the fastest food chains, everything is risky to our health, we still, or everybody wants to relish many of the things, and we know that our food is killing too many of us. Next slide. And apart from that, a few note on the ultra processed food items, where the NOVA food classification is also given here for a reference. Why I added this here is to note that this is also another alarming cause for the rise of kidney diseases. Next slide. And the given graph says that the intake of ultra processed foods, how the weight change is happening with the intake, and unprocessed food intakes when consumed, the weight is also maintained, or it can be decreased with proper lifestyle management. Next slide. So we know that processed foods and beverages are silent killers, and the extraordinary science of addictive junk food, no need to explain much in this regard. Next slide. And this WhatsApp image I recently received, most of you would have received it. We are talking about technology, and everybody is using technology in day-to-day life, while sleeping, studying, eating, even while using toilet, many are using the mobile phones with them. So people are not new to the technology. It is with them. Even the newborn baby is made calm with the mobile applications or Play Store items like that. So this looks so applicable here. So I just added the photo. Okay, next slide. While coming to diet consultation methods, we have conventional consultation like one-to-one approaches, and also digitalized approaches, as post-COVID era has given rise to more applications and more positive chances for the development of digitalized options. Next slide. So the relevance of technology we need to find out or explore much in the nutrition therapy of renal diseases. Yes, it is providing digital nutrition interventions, AI-based consultation, artificial intelligence. It's really an emerging field with nutrition technology. Mobile apps, n number of apps are there. Doctor was pointing out few names. In India, I don't think it is much common, but abroad it's using even for renal diseases. India, we have many apps for the common lifestyle diseases like diabetes, obesity, even PCOS also. But the rest, the person-specific critically ill patient-specific apps are yet to explore, and my research was an effort to bring into the light. I'll explain about it after, when we go to the recent slides. Then the nutrient trackers are possible. All these things empower the patient or their bystanders to do the self-management of the medical nutrition therapy of uh, renal nutrition. So it is to emphasize the management of by the patient or their caretakers by themselves, rather than depending on the healthcare provider each and every time. So small queries and things can be addressed. Of course, there should be a monitoring. We cannot completely give away everything to the application, but yes, it's a handy tool with them, so that the dietitian's presence is felt day in and out. And this supports to provide effective data output, monitoring, analysis, and documentation too. Now, next slide. The nutrient calculations are made easy. During college days, I don't know how many of us remember, nobody can forget, I think, the calculation, the amount of volume of time we put for the calculations of nutritive value of ingredients. Now we have many apps present, and just entering the data or the ingredients itself will give the nutritive value. And micronutrient values are found out within minutes or within seconds. So that is one advantage. Next slide. Another one, as discussed by the previous speaker, we have advanced applications to capture images, and with the images, with the sensor acts, and the nutritive value, even the oil content can be measured from this. So such applications are the futuristic promises where a renal patient can assess or access how much even the oil or salt or even micronutrient, also how much it is there. So that has to be developed still. It is a much to be explored area. Next slide. Then to provide personalized nutrition plans, there are many applications where they provide flexible goals for the common conditions. And there are personalized approaches for specific conditions too. So each one, depending on the package preferred by the client, they can choose it and utilize to their satisfaction. Next slide. So the personalized approach, we talk about this aspect day in and out. Same like all the other cases, clinical follow-up requires medical nutrition therapy of renal patients with the personalized approach. And as Dr. rightly said, AI or artificial intelligence has much role to do here. It gives us the fastest way to predict things is one option, and the real-time data can be obtained by this. It can streamline the tasks which would otherwise take much of our time. It saves time and resources, assists research. That's very another advantage with AI, because in the hospital, dietitians do all documentation and all follow-up, but we don't have time to document the data for the research purpose. So once these apps come into picture, the data, whatever we enter, will be stored in the backup, as a backup. And with that, we can take out each data as required, and different statistical parameters can be applied. Certain apps like they also they will have integrated integrated Power BI kind of tools also will be there. So it themselves will give the graphs or statistical analysis corresponding to the data. And accuracy is another advantage. It can reduce physicians or dietitians or any other healthcare providers stress and time too. Next slide. These are few mobile apps which Dr. already had mentioned on these things, so I'm not going in much detail. So these are all the efficacy analysis have been done, and we have certain, next slide, we have certain references or research points also to find out the efficacy or the how to explore all these things. And this report is a systematic review where the nutritional mobile applications for CKD patients was studied, and it showed that the apps show promise in CKD self-management. So it was emphasized that these apps are effective in the self-management of renal diseases. Next slide. the same study was suggestive that it replaces the old-fashioned food diary with digital recording. Now, we were asking the patients to write down whatever they are consuming for the next review. So the writing, nobody is using a pen or paper now, only mobile is there. So if with these apps, they can right away feed whatever items they consumed. Even a small snack can be entered, the name can be entered. And so it saves time and resources. Anytime, anywhere they can enter, it will be saved in the data. And when the next review comes, it can be viewed by the dietitian to see the nitty-gritties of what the patient was consuming and where the variations, if would have happened, they can point it out well. Rather than writing in a piece of paper, it gives much accuracy in data recording. Then simplify food and portion selection processes. With the support of an application or visual effect, the portioning is made more easy. In the conventional approach, we suggest small portion or cup, katori size, things like that. We will have an assumption of our measuring size. The patient or the client will have their own visual imagination. So that both may not match always. So with this application usage, both the parties, the consultant, the dietitian and the patient, both are coming to one platform and mutual understanding is happening and more support can be provided to the patient. Then existing apps having advantages such as text and search and a barcode scanner for data input. So a camera for taking pictures so that real-time images can be sent to the consultant dietitian for them to know whether it is good or not. Or so many of the apps are having these resources right now and people are making use of it. And this study also emphasized that it would not replace the role of a dietitian. When such applications are coming into picture, the first fear happens is, will this replace me? Because this is giving diet plan, this is patient is finding it more easy, patient is using it for more follow-up and more changes. So whatever data I'm feeding this, patient is making use of it. So will I be replaced? So that's a normal thought which can go. It will not replace dietitians, provided dietitians get updated with technology and professionally. So one size fits for all concept will not work out in this scenario. The world is advancing, clients or the patients are advancing. So we too have to advance digitally and professionally. If that is assured, technologies will definitely support us in managing or helping out patients. If not, less competent people will definitely be replaced. That is a fact. We have to accept that. We cannot fight for our demands, nothing like that. So technology will get advanced. So whoever can adapt to that, update themselves, will stay with the flow or will go with the flow. So this is challenging to each dietitian over here. At the same time, it's helping us to empower ourselves so that we are going with the patient or going with the world's pattern and we understand things. So it is supporting healthcare providers, provided we are also getting updated in all the aspects. Next slide. Another cross-sectional study found out the prevalence and opportunity for technology use in chronic kidney disease patients. They concluded that here the younger patients were more likely than older patients to use mHealth, mobile health technology, and interactively, although all patients' technology literacy ought to be thoroughly assessed by renal teams. So that is the medical team has to assess before providing such an application to a group of people or the patients. Their digital literacy needs to be assessed properly. Younger generation may be easy, they can easily adapt to these changes. Older generation may need some training. So that being a healthcare provider, if we are asking them to use the application, we need to understand their understanding level and then we can slowly make use of the technology changes in their pattern. So it brings out a behavioral change. So that change will be evident with data documented so that we can record the changes. In the OP, in the conventional method, we'll have to use so many papers and registers, and we'll forget something, we'll miss out one paper. So it becomes a chaos. But in the application, one person's data from day one, it will be entered, or the progress will be shown in each visit. So the searching the data is more effective, time saving. So those kinds of benefits will be there with this. Next slide. Digital health interventions, they are designed to improve health literacy, self-efficacy, and health-related behaviors. So the current article given here, it discusses the potential of digital health interventions to level the playing field for patients with CKD, as well as steps the researchers. So this needs collaboration with the patients to make a proper tool. So all the articles are suggestive of using the technological changes in the medical nutrition therapy. But every article, as a conclusion, they suggest the collaborative approach with the patient, and furthermore to explore in this field in different areas. So there's a wide area for the research in this management of CKD using digital technology. Next slide. mHealth, the assessment availability acceptability. This study reveals that many patients or many individuals with CKD currently use the internet and smartphones and are interested in using mHealth in the future. But few use mHealth apps or have adequate e-health literacy. Next slide. The concept is shown in this pictorial way. The figure also depicts the same. The study findings are done in a more easily understandable way. So here they need to get trained. The training is being emphasized in almost all the research papers. So this has to be understood. This is not like something for the Play Store. This is dealing with the day-to-day intake, output, and the corrections, updates, follow-up, and things like that. So it's like a live doctor or live dietitian. It has to support the patient. So it should be planned in such a way that it makes the patient's life easier. Small doubts when they have, a chatbot facility can be used, and this will support them in correcting small things. And of course, this should be monitored by a trained dietitian who gives a personalized support. Usually in the hospitals, what we find is we don't have much of time for the personalized follow-up plans. When they're in the hospital, we will be meeting them. We have assigned dietitians for meeting them. But when they are back home after discharge, that follow-up is 100% not happening in most of the hospital setup. So this kind of technology will be useful for patients in such conditions where we can manage a wide variety of patients. And another advantage is doctor also can view their nutritional intake and dietitian's remarks as a real-time data. So those are the benefits which this can bring out. Next slide. Another study by Ferre, Genser, Bingo, and et al. Found that they just did the development of a smartphone application to increase dietary compliance in patients with chronic kidney disease. This also was conclusive that the application is updated according to the evaluations and suggestions by the participants, and the final application was formed to be ready for the use of patients. So after getting the patient's feedback, they modified it and then made personalized. So with all these in view, I would like to present my findings during the COVID pandemic on my research on the development of the mobile application. Next slide, please. This is a publication came in International Journal of Food and Nutritional Sciences, where just did an evaluation on the digital nutrition consultation among handheld device users during the COVID-19 pandemic. Next slide. And a few remarks or the few features which are relevant to this area of discussion I just brought here. When we compared the choice of diet consultation appointments by the respondents, around 1,090 participants were there. It was an online survey with Google form. We could see that majority of the participants, around 43%, preferred one-to-one consultation for the initial diet consultation appointment. Next slide. Then another questionnaire was provided where 1,029 participants gave their feedback that for the follow-up, they preferred smartphone option, because first consultation, I think they wanted to be more knowing or more personalized the thing, so that once they feel comfortable, they were using the suggesting for the smartphone follow-up. So this was supportive for the data what we found. And next slide. Another study was conducted during the peak of the COVID, June 2020 to December 2020, 6 months study, where the comparison of the trend towards newer diet consultation options were found. A few criteria like email queries, teleconsultation, video consultation, and quick messenger services were provided, and QMS scored the more with the given number of respondents. So it was showing an increasing trend towards digital diet consultation during the COVID pandemic. So based on these findings, next slide, the mobile application called My Dietitian was developed, and it was circulated for over a period of 3 months. Since it's a study app, it was not commercialized, but the people were encouraged to enter their data and find out the efficacy and how things were like that. So these are the few visual effects, the few interfaces when we approach. So here diet plans, customized plans were provided, and further approach will be provided through a personalized diet consultation once the patient goes through the initial cycle. And there were food search for nutritive value. Similarly, search option by calorie count was also provided. So these were and the best part is why this application development process took place is, for the hospital dietitians, a reliable tool we still don't use in many of the setups. I don't think everybody is using it. Maybe in few setups it will be used. But the rush hours, if we have such an application, it will give the data backup with us, and we can further check the patient's progress by doing the Power BI enabled statistical analysis. Next slide. And this presentation or the development analysis was done with regression coefficient, and it was supportive for the development of such applications. It was found to be user friendly, information was clear and detailed, and these are the few parameters which I projected, and the responses were obtained. So as a conclusion with the presentation of the next slide, of the development of the application, it was seen that the personalized diet consultation was preferred by persons who prefer to be consulted in their own convenient setting, and the data was supportive. Then proper nutrition intervention and monitoring can be provided with people bringing about the changes in their pattern. It was found to be a consistent method, where online method was found to be consistent when compared to offline, because the patient drops were more observed during the offline method. Or they'll come only if they need, or if they have to consult the doctor, they'll come. Otherwise, for their own purpose, to meet a nutritionist in the hospital was not that consistent, other than a few category of post-operative and PCOS or high-risk pregnancy cases. Other category was not that effective. So in this study, it was found that online consultation, digital applications were more effective. And while coming to our topic of managing CKD, the MNT in the CKD, such technologies will be shaping the future of global health, and it was found relevant right from the COVID pandemic. So anybody from anywhere in the world can approach the dietitian for their nutritional needs. Cloud technology, cloud computing, blockchain protocols, AI services, everything was highly appreciated, and still it is getting explored. Next slide. It is not that we don't know about diet that most threatens our health. It's a constant wild misrepresentations of what we do know. So here also things can happen. There could be much appreciations or oppositions to the digital technology innovations. But yes, world is progressing. Digital technology is progressing like anything. So this will grow up, and we have to change with the scenario. But definitely it is not changing the dietitian's role, it is becoming upgraded. We are getting empowered to use technology in a more efficient way. Next slide. Here are few publications and related readings with AI integrated technology, cloud computing, and online consultation services. So it's for your reference. I just noted it here. Next slide. This is from my end and from on behalf of my team, Department of Clinical Nutrition, VPS Lakeshore, thanking you for the patient listening. Thank you.
Thank you so much, Manju. Thanks a lot. So it was a wonderful session by you as well. So as rightly said by Sir and by you, technology is something which is not restricted only to the IT, but also the use of the tool that we have for the betterment. And I think then when we're talking about technology, should be focusing on the situation of what we are looking at. We are looking at the patient friendly or at the healthcare provider friendly one, and also the resources which are available at hand. So, sir, my first question to you is where we're talking about technology so much about using different tools for measuring the UACER and for the BP measurement. Still, in many places in India, even a simple weighing scale is not available to measure the body weight. And we still struggle with the dietitian as to what should be the weight we should be using to calculate the protein and the energy requirement of the patient. So maybe if you would want to bring some insight into that.
Okay. Let us not defend the indefensible. The indefensible is we do not have basic resources. I think the my response to it is we must provide basic resources for any kind of progress to occur. Now, technology can bring down cost, as we saw in mobiles. AI, mobile apps, all these things will become cheaper as days go by. But ultimately, there will always be a price which will have to be paid, however small it is. So the only thing that my response is make these basic resources available. Weighing machine, reliable blood pressure apparatus, reliable blood glucose estimation, reliable laboratories to estimate serum creatinine. Now, a serum creatinine reported by a laboratory has to be linked to an IDMS standard. So the laboratory must have quality control, external quality control, and then only that creatine and EGFR derived from that creatine will become reliable.
Correct. Right. Yeah, that's what happens, like in the rural setup, especially doing a creatine or a UACER is something which is not very routine. And by the
So about
time,
UACR, let me tell you one thing.
yes,
You,
sir.
all over the developing world, urine albumin creatine ratio is not done frequently. What we are doing is urine protein creatine ratio. And the heat map, which is being generated and used to classify patients with high risk of rapid progress of renal failure, uses urine albumin creatine ratio.
Yeah, sure.
So
Correct.
there are two ways in which we can approach the problem. We can improve resource allocation in even developing countries and use urine albumin creatine ratio, or we can use a mathematical equation to convert urine protein creatine ratio to urine albumin creatine ratio. If you Google this, you will find that equation also, because urine protein creatine ratio, as it increases, the predominant element is albumin. So at higher urine protein creatine ratio, albumin creatine ratio and protein creatine ratio match. The problem occurs when protein creatine ratio is very low, and that means the albumin creatine ratio is very low. At that time, you have to use the albumin creatine ratio only. You can't use protein creatine ratio.
Sure.
But for larger amount of proteinuria, you can use the converter
Correct.
formula.
Correct. So, sir, any inputs on how we can use this for a community setup, or how do we do a screening of the renal patients in the community setup? For
Okay.
diabetes, it's very easy. We do the blood pricking by a glucometer. For the BP measurements, we have the we have the BP instruments to measure the BP. But where for the community-based renal nutrition, renal screening becomes a little difficult.
Yeah. So the answer is I service and I'm quite interested in a problem known as chronic kidney disease of unknown origin. In the foothills of the Satpura Hills around Pusat, there is a big epicenter, and the entire communities are suffering because of chronic kidney disease of unknown origin. So we want to do a mass screening and find out who are the people who are affected and who should be then asked to likely to be affected and then asked to go in for a serum creatinine test, which is a more expensive test. So when we are going to conduct a health camp in near future, we will be taking two kinds of strips. We will be taking a simple urine routine strip with only glucose and sugar, albumin, protein.
Hmm.
If the urine strip shows 1 plus proteinuria, that means there is significant proteinuria.
Hmm.
But those who are in the high risk and who have albumin negative, for those we will use this micral test, micral
Okay.
dipstick, and then find out. So that way, that's how. And then if the micral is positive, then the patient undergoes a creatinine estimation. If dipstick is positive, then we will not test it with micral because obviously 1 plus means there is heavy proteinuria, large proteinuria. That individual will also get a serum creatinine tested.
Okay. Okay. Right. Thank you, sir. Manju, are you there? My next question is to
Yeah, I'm
you.
here. Yeah.
Yeah. So you spoke about the use of technology very nicely in managing the patient where nutrition is concerned. Now, how much time would you as a dietitian averagely spend on every single patient if he or she is sending you the photographs and talking and discussing? Because what happens with them is they are expecting an instant answer from you whenever they are putting something. So how it is where time management is concerned from your end?
Yeah, at present, with the application, I'm not doing. It was a study app, and for that period only it was done. But in the hospital, we have two types of consultation. One is conventional, and for the first consultation is done as conventional only. And those who require a continuous follow up, we give them a quick messenger service option. So these patients will be sending their recalls either as photo or as their recall writing or the print or something like that. And this will be, we have already told them within 24 hours we will be responding. So they cannot expect a quick answer because they'll be sending it during daytime and will be on the rounds or OP consultation. So in the meantime, we'll be noting it down and required either we'll call them or by WhatsApp or email. We'll be informing their modification. So that is being considered like that. So an OP normal way, minimum 30 minutes, maximum 45 minutes to 2 hours it will take. In the online consultations, telephonic is also available. That also will take 45 minutes minimum, so that the patient wants to know everything, whatever changes they require. Online also, since it is texting is involved, on and off it will be there, so it is not taking much of time. But if we want to talk to the patient over phone, yes, it is taking some time. So time is the main constraint. We need more people to train people to follow up such patients.
Correct.
I have a question for Dr. Manju.
Yes,
Yeah.
sir.
Dr. Manju, compliments on developing that app.
Thank you,
Very,
sir.
very good work. And I want to ask, who were your technical supporters? Because I have been trying to develop an app for dialysis technicians, and I realize you actually do not require software engineers to help you in developing an app. All of us can develop an app. Is now a movement towards no code app development. Caspio is one brand which can offer you this. I use Caspio to first
Okay.
create Excel sheets, and
Uh-huh.
then having created that, the next step is to post that app data sheets onto a platform. One such platform provider is Square. So, what has been your journey? How have you developed that app?
I gave it to software consultants only, sir, because it was during COVID time, so I had to depend on them, and few freelancers were available. So at that time, I gave making them understand the nutrition concept was a little challenging. So other than that, the development was done, and by with consecutive follow-ups and error corrections, trials, everything, it was finally done. The app part I didn't do on my own. It was outsourced. The nutrition integration suggestions were done by me.
But to my knowledge, that costs a bomb.
Yes,
Software development.
definitely it had.
You had an angel investor investing
No,
in your.
no, no, nothing, nothing. I started with a small thought, but since it is a PhD research, it had to show some decency and trust to the study. So it was, yeah, app development is costly.
No,
Yes.
this app which you developed, did you take professional help or they were also engineering college students?
No, no, no. Professional developers only. Developers only.
How much did it cost?
Altogether, it was 5 to 6 lakhs. Sir. I didn't go to the AI based advanced thing. So if it was in an AI integration was done to show that it was possible, but more studies would have been done if AI was little more percent was there. So only 2%, hardly 2% AI was there. But I wanted to show hospital based dietitians also can develop such things and they can use it.
Yes, yes, they can certainly do a great number of
Yeah.
things.
Thank
You
you,
have
sir.
That's
really
what,
shown.
after my lot of contemplations about using the app or not using the app, I have satisfied myself with the WhatsApp. It becomes easier. It's easier for the patients also, irrespective of their socioeconomic status, and the language barrier also does not
Mm.
become a hindrance when that happens. Because with the app, I think the thing about different languages and about visuals and everything comes into play. So it becomes more tedious as well, I guess. And it comes a lot of backend information which is required, the storage data and everything in there. Right. So, Manju, tell me about like when this app was being developed or when you are using the app, how do you talk about the portion control? I could see there were a couple of clippings there about the portions as
Uh,
well. But then,
okay.
there's also one question here in the QA box which talks about the plate wastage or the food wastage, which happens when the patients, especially in CKD patients, because they are already complaining about anorexia and nausea. So, how do you overcome this when you're talking about the app or in general when you're talking with the patient through a digital medium?
Yeah, in the while using the app, what was done was I had given the portion size in the tracker. So 1 cup measure was 200-gram cooked volumes. That was informed, and the nutrient calculations was done based on the how much raw will be there to reach the 200 grams. So based on that, the calculations were done. And wastage, there was no specific portion developed in this app, but there is a chatbot facility available where they can the person can ask how much this I mean any queries they can ask, and within 24 hours that was answered. So it was done like that. So it, since it is not a commercial app, there it had certain drawbacks too. So this was noted, and if it is somebody is using it as a professional purpose, definitely it can be overcome.
Okay, great, great.
Yeah.
Thank you so much. Thanks a lot. Yeah.
Thank you.
So there is one question for you, Manju, about can you give us the name of the app? I believe they're asking for the name of your app. Is it available commercially? It was only for your
No,
research
no, it
purposes.
was for the study purpose because it is just in the stagnant state now. I did for the 3 month study, but the name is My Dietitian. Dietitian. So it was the app in the Play Store. It was available for free during that time. I had given links to many, mostly not to many critical patients, or to all those who we follow up just to know their feedback, and also to my friends and colleagues. They were using for the efficacy test, and patients we cannot test them with this, but those whom I know, I gave it and they gave their feedback. So based on that, the final tuning was done. So the name was My Dietitian. It is not at present, it is not active, but just wanted to see, show this kind of a possibility is there other than the weight loss apps and things like that. So we need more personalized approach and patient centric apps in the critical care setup. That will be more convincing and hand holding with to the patient.
Correct, right. Yeah. Thank you. Thank you. So I have one question for you. When we are practicing here, the time that you spend with your patient is very, very important for the patient point of view also, and from your point of view as well. And the patient feels more connected the more time you talk with them. So now with the advent or using of this app, do you think that personalized touch would be lost, and how would you overcome it as a nephrologist?
No, no, no. Just the opposite. We must have apps so that we can give time to our patients. So a lot of time in nursing is spent on data capturing or for dietitians also. And the most important thing for what a nurse and a dietitian should be doing is behavior modification. She should not be wasting time data capturing. Data must flow in. Having the data on your desktop or on that screen will help you in making some kind of hypothesis And then what requires real time is to motivate somebody to change his behavior. And then once he tries to change his behavior, he sends you another new set of data, and then you encourage him, then you remove all the small obstacles in his pathway, and that's how behavior modification occurs. So
Right.
unfortunately, our current system, we spend a lot of time on data capturing, and all of us capture the same data. Many
Correct.
of us capture the same data, and very few of us then have time left over for the next action.
Right.
So I think apps will come a big way, AI will become a big way, and that will change the face of medicine that we have.
Right. So thank you so much, sir. Thank you. I mean, it was a wonderful session that we had, and hopefully we would be seeing more data flowing in where the use of technology is concerned in the renal patient management. Thank you so much for being here, Dr. Kalkar and Dr. Manju. We'll be having our next webinar on the February 4th Thursday. I'll be floating the details soon about that. Thank you so much. And if any of you has any topics which you want us to take up in the webinars, please let us know about it. Thank you so much for being here. Thank
Thank
you.
you.
Thank you.
Thank
Thank you, Human. Thank you, doctor. Thank you,
you.
everyone.
Thank you.